It's an incredible pleasure to welcome some amazing past presidents that we have now on panel. And thanks to our program committee chair, Kelly LaFave, for coming up with this idea to invite our past presidents to come and join us to share some of their wisdom and some of their exciting things they've done during their presidential years. And then Mo will lead a further discussion. So Lori joins me in welcoming our past presidents. So I'll start by asking Dr. Richard Cruz to turn on his camera and say what the highlight of the year that of his presidency, and give us a brief introduction to his year that he was a president, and then the priorities during his year. Thank you.
Thank you, and congratulations for an unbelievable year and a really inspiring address. I was the president in 1978, and frankly, it's so long ago that I have a lot of difficulty remembering priorities and difficulties. What I can say is something that sort of links with your current approach to life. 1978 was 8 years after the introduction of Medicare. It was a time when inflation was running anywhere between 10 and 15%, depending on the year. And government was using inflation to curb expenditure on physician services. We went from 1.3% of the GDP going to physician services to 1.1% in about 6 or 8 years. And by the way, we were never poor. We never had difficulty buying shoes for our children. So I don't think we had any right to feel sorry for ourselves. But shrinking purchasing power does catch people's attention. So it's sort of interesting. The first thing we did was to bring together the provincial associations, because under our constitution, healthcare was provincial, and there were fee schedules that were different in every province. So I think it was the first time we brought together the presidents of the provincial associations, and we did so to try and share information and see if we could develop common policies. So that's, I think, a kind of a direct link to today, and the message was about the same, was that we were stronger working together than working separately. So that's my brief narrative, my brief story, I guess, to link with the president.
Thank you so much for sharing that. Now, Dr. Mervyn Tao. If you can turn on your camera, please.
It won't go on. Oh, here it is. Okay. Hi, everyone. It's wonderful to be here. Dick, great to see you. At least there's one president before me. I was president in 1992, and by far what we spent most of our time doing was planning and then executing the combined meeting of the English-speaking world in Toronto at that time. Here's a nice picture of all those presidents from all over the world in Toronto during that meeting. Since it only comes up once every 30 years, we're coming up, I think, 30 years next year. So it was a big event. We had the opening at Roy Thompson Hall with the Royal Canadian Mounted Police Band before they disbanded, and we were also at the convention center, and we took up most of the hotels. We had more than 3,500 surgeons from around the world. By any measure, we were really pleased, and it was just a great success. So we enjoyed our travels, as all of us did, but that was what we were mostly doing for that entire year. I'd like to just mention one other thing that happened that year. My great mentor was George Pennell, who was the COA president in Halifax in 1965, but but he was one of the early people to try and get the foundation going, the COF. He was very, very interested in that. So for the first decades of the foundation, it was mostly getting money from other surgeons. But around 92, we started saying we need to get money from the public. And that's when we started talking about our grateful patients and maybe a walk. And my wife Esther happened to be at a foundation meeting when people were talking about hip this and hip that and hip replacement here and hip, and she said, "Wow, hip hip hooray." And so was born the name Hip Hip Hooray. Esther's right here. She can wave to you. But we're always proud of that. And I'm sure George Peddle just would have loved that name for sure. Anyway, we love being at the COA. It's just the most fantastic organization, and it's gone from strength to strength. All the best to all. Take care.
Thank you, Dr. Tal. Dr. Waddell.
Can you hear me? Yeah, okay. Well, I was the president in 1998, and the thing that I wanted to do, and which we did, was try to streamline the organization. When I became president, we had 42 committees in the COA, and the chairman of every one of those 42 committees had to give a report at the time of our business meeting. And so I slimmed that down pretty dramatically. And at the same time, I recognized that there was a tremendous increase in the strength of the provincial and regional organizations. And I was afraid that there would be a negative effect on the COA membership as a result. And so I invited the presidents of the provincial and regional organizations to join the COA board. And so I think, as I would say, that was the major accomplishment in my presidency, was to try and bring, and as Dick Cruz said, work in a common way to develop national programs that were relevant to every province and every region. Thank you.
Thank you, Dr. Waddell. Now it's Dr. Rohraback.
Well, hi, everyone, and thanks, Dr. Bandari, for organizing this. It's great to see everybody. Now, I was president in 2001. So Mo, like you, being president at a difficult time, I was president when they had 9/11, of course. And that did impact our year, not to the extent COVID did, but it certainly impacted attendance and that sort of thing, and some travel with our American colleagues. But notwithstanding that, I would say that the principal thing that I think I did, legacy, was hiring Doug Thompson. And Doug, I think, fantastic steward to the COA over many, many years. And I'm taking credit for telling Doug that he needed to get a life, get out of Depew and come and work for the COA. So I think that's my major accomplishment. Now, there's other things that I did along with others. Was starting the Canadian Joint Registry. I didn't personally do that, but I think I was integral in getting guys like Bob Bourne and Baz and Clive and Eric Bone and so on together to get this thing going. And I think it's been highly successful to this day. Probably the most interesting thing from an audience point of view that I did was I found myself in Tasmania representing the COA, and I became quite ill in Tasmania to the point where our host said, "Cease, you need to be in a hospital." So anyway, I went and I found myself heading to the hospital, and he said to me on the way to the hospital, Now, would you rather go to a public hospital or a private hospital? And I said, private, of course. I've never been in one. So I spent probably a week or so in Tasmania in a hospital, being very, very well looked after. So I missed the Australian meeting, missed the New Zealand meeting, missed the South African meeting. So that was really the end of it all. But I met some lovely people and terrific caregivers, particularly in Australia. So it was a great year. And I want to thank you and all the members of the COA for what you've done, the contributions that you've made.
Thank you. Dr. Clive Duncan. Clive, can you get your audio on? Unmute yourself. There you go. Thank you, Clive. Okay. Clive, we can't hear you. Okay, so we'll come back in a minute if we could come back on live. Okay. So we'll go to Dr. Hollencheck. Thank you.
Good afternoon, and thank you everybody for what you've done for the organization. In June of 2003, my inaugural meeting as COA president in Toronto was canceled due to the SARS epidemic. That meeting was subsequently held many months later in October of that year in Winnipeg. We said at the time that such an event would very unlikely, I think we might have even used a snowball's hope and hell analogy, disrupt a future meeting, but we couldn't have been more wrong, obviously. One of the highlights of my time as COA president was being present at the Supreme Court of Canada as an intervener in the Shauli case. That case was from Quebec, and I was on the CMA board of directors at the same time, and I was able to convince the board of the Canadian Medical Association to partner with us and intervene in the Supreme Court action. In that action, the argument was that the patient, Mr. Zeliotos from Montreal, had had his charter rights to security of the person violated. He had been on a waiting list for almost 2 years in pain, waiting for a total hip replacement. This man and Dr. Shauli, his family doctor and legal advisor, interestingly enough, won their case. And this allowed some private surgery to be available in Quebec, but not elsewhere in Canada. The best part of this partnership for the COA was that the CMA paid for all the legal fees, which were quite substantial at the time. Almost 12 years after the trial, I was an expert witness in Brian Day's BC Supreme Court case, arguing that BC and Canada should have the same system of parallel public and private healthcare that exists in the rest of the world. That case was unfortunately lost, but it is presently before the BC Court of Appeal and likely headed, like Shauli, to the Supreme Court of Canada. That Supreme Court of Canada decision, unlike Shauli, would apply to all the provinces and territories in Canada. Thank you very much.
Thank you. I see now Dr. Duncan is back. So Clive, can you turn on your microphone? Sorry, Clive, we can't hear you. Yep, go for it. Yep.
Can you hear me?
Yes.
Oh, I'm not going to even see myself. Thank you, Kish. Thank you for all your patience as I try to join you. I finally got on a computer here that has no camera, but I've got the iPhone going. Mo, great idea. Thank you for inviting me to participate. I was the president during 00102. I was able to take advantage of many of the things you've heard of already. One you didn't, and I'll come to that, and then another I'll bring up. First, become a lot more expert in advocacy for our patients. And there were a long line of presidents that helped to get to that point, including Dave Petrie and Cy Frank, who are not with us anymore. But we became more expert at dealing with the media and with government. And we also learned how to collaborate with some partners who had the same interests in our patients as we had, who'd already reached to that point of advocacy very effectively. And I'll bring up just two, the Osteoporosis Society and the Arthritis Society. So we managed to get successfully into advocacy and to train ourselves how to advocate on behalf of our patients. And I recall we would have training sessions on the subject of what is the message, stay on message, because the only message we're used to staying on is when we're doing informed consent with our patients. We're not really that good when we're confronted with a reporter who has questions that we may not be interested in answering or don't know a great deal about. The second thing we had been struggling with was the membership of our association, which for many years never rose above 80%. And we were very concerned about that and finally identified perhaps the salient point, which is we had to become more relevant to their professional lives. And so the educational content of the associations effectively changed over a number of years with emphasis on symposia, instructional course lectures, etc., after a number of national surveys to which we got a very great response. Cease is absolutely correct. It's hard to believe that we were able to run this organization without the expertise of someone like Doug Thompson. It was a brilliant move. We basically looked after this ourselves. And that was one of the reasons we had to have so many meetings, winter meetings and so forth, as we tried to administer this organization that's becoming larger and most effective. And what was unique to my year, something like what Marv Tile has brought up, is that our friends in the American Orthopaedic Association asked if we could have a combined North American meeting, which we did in Victoria in 2002. The AOA and the COA are very different. We're more aligned with the American Academy, so to speak, because we're involved in research and education and so forth, rather than the mission, vision, and values of the AOA, which is on leadership, practically confined just to leadership. So it was a little bit of a challenge to blend the AOA culture with ours, but I think we were successful. And I've really got to tip my hat to Cease Rorabeck, who worked hard on this with me, because their desire to join us was made evident 2 or 3 years beforehand when Cease was in the presidential line, and he was of great assistance in making the Victoria meeting success. So much so, I think they asked for yet another 4 years later, which was in Quebec City, and I'm not sure how many more there have been, but it was a very successful enterprise. So I have great memories, warm memories of that year, and I really appreciate this opportunity after more than a year to see old friends, and particularly to see Dr. Cruz and Dr. Tile, two heroes of all the rest of us on this screen. Thank you, Mo and Kish.
Thank
Thanks,
you,
Dr.
Clive.
Duncan. Yeah, and thanks, Kishore. I'm going to continue on our chronological journey through our COA presidents and introduce Dr. Brendan Lewis.
Hi, thanks for the opportunity to participate. This is a great meeting and certainly good regrouping with regards to having the virtual meeting, and it's been excellent joining it. In my year, I've been in Corner Book now for the last 30 years. My year of presidency was in 07, and I was probably one of the only community orthopedic surgeons that was president in the past. And for my role, I felt that we need to build up a membership and grow with what had been done previously with the previous presidents of the organization. So we reached out to many individuals, including community orthopedic surgeons, to become involved, and also importantly reached out to our Quebec colleagues to try to encourage them to become members of our society. Since then, we've had one individual who has been president and as a community orthopedic surgeon, which has been good. And I want to commend everybody that has been involved with the meeting itself. It certainly was a shame missing the meeting last year, but I must say, even with this virtual thing, that the work has been great and the presentations have been excellent. So Mo, thank you very much for your leadership.
Thanks, Brendan. Next is Dr. Peter O'Brien.
Thanks, Lori. I started my presidency at the Quebec meeting in June of 2008 and finished at the Whistler meeting in July of 2009. During that time, Doug Thompson, Cynthia Vesna, and Trinity Whitman were the full-time employees of the association. And I need to recognize the incredible work that those three did in keeping the COA on track in terms of serving the orthopedic surgeons of Canada and ensuring excellence for orthopedic care for Canadians. I had the privilege of being between two outstanding presidents. Mark Morrow was the year ahead of me, and Cy Frank the year following me. There was one, I think, unique thing that happened that year, and that was related to ethics. Many of you might recall that in 2007 and 2008, in the United States, the Department of Justice was investigating 7 major orthopedic implant companies for their relationship with orthopedic surgeons. The allegation was that the companies were paying orthopedic surgeons for preferential use of their implants. And that was against the law because they had an anti-kickback law in the US. And the majority of those companies agreed to either a deferred prosecution or a non-prosecution agreement. Nobody, or there was no conviction or admission of guilt, but those companies paid hundreds of millions of dollars in fines as a result of that investigation. We were worried in Canada because the law in the US allowed that companies that had their headquarters in the US might have to investigate their actions in international sites. And there was an investigation that was started in a hospital in Melbourne, Australia. And the other thing that happened that year was that the New York Times reported that after they'd finished investigating the companies, the Department of Justice was going to start investigating individual orthopedic surgeons. Now, there was certainly no allegation or evidence that there was any kind of that activity going on in Canada, but we certainly needed to look carefully at the orthopedic surgeon's relationship with industry. And at that time, just before the Quebec meeting, the COA Code of Ethics was released to the membership. And if you look at it, you'll see that the appendix at the end of that code is all about surgeons' relationship with industry. And I think it's an important thing. It's evolved a lot since 2008, but we had an interesting year discussing ethics. We also had a strategic plan that year, and based on an environmental scan and a review or a survey of the members, identified 3 areas that we wanted to focus on: advocacy, modeling of care, and outcomes. And I had a few other personal things that I was interested in. One was diversity, equity, and inclusion. At that time, at least 60% of Canadian medical schools were attended by women. 20% of the trainees in orthopedics in Canada were women, and 6% of the COA membership were female. So we needed role models and leaders and mentors to bring the women along in our association. I'm so pleased to see that Lori it's taken way too long, but we're finally getting there. And the other thing that we were interested in then was global surgery. And I'm pleased to see that Kishore is taking over, because I know that's something that he's also very interested in. So thanks for listening to me.
Thank you so much, Peter. Next up, Dr. Ross Layton.
Yeah, thanks a lot, Lori. Appreciate it. Thanks a lot for the invite, and been great. We had about 10 or 15 minutes before we started, so we were able to say hi to everybody. So my presidency began in Alberta with Cy Frank handing off to me, and then of course I spent a great party in Newfoundland at the final event in 2011. And Lori and I walked down the street together one time in Newfoundland, a very sunny day, which is quite unusual in Newfoundland. We had a good time there, so that's a good memory. So thanks for the invite, Lori. So my year really wasn't nothing compared to the COVID situation for sure. The only thing that really happened from a international aspect was really the metal-on-metal component failure happened about mid-year. So it was kind of nice because we had all the presidents were together at that time. So we developed an international policy on what to do with the metal components. We were able to bring that back to Canada and distribute it through all the provinces through the presidents of the associations of each province society. So we actually had kind of a nice international policy that went through Canada that was kind of interesting and nice, as opposed to trying to decide on your own what to do and then figure out what the other countries were doing. So I think it was a really nice way of dealing with that particular event that seemed to bring us through it without too much of a problem, although it was problematic for some of our patients. It was fortunate Canada didn't have a lot of metal components going in at that particular time. As far as the future goes, I think since I'm in the last decade, I can look a little bit at the future, but I think that the two things that I was interested in, and I still think have some traction to go, are really education, where I think that the Canadian Orthopaedic Association should become the educator for MS block throughout the whole thing, with nursing, with the cast technicians, all those things, similar to the OTA that provides educational courses for that at their annual meeting. And I think we could enlarge our meeting, enlarge our membership, and become the educators. And all the people that teach those courses will be at the meeting anyway. So I think it's a great spot to do it. And the final thing that I think really has come along, and congratulations go to the Canadian Orthopaedic Foundation under Pierre Guy's leadership, it's really improved a lot of the research educational grants that are there from the COF. And I think the COF is really becoming that arm of the Canadian Orthopaedic Association that's going to get an endowment fund and fund research, and we've got special awards. So I really think we're on a good point. As the presidential address said by Mo, we have a great situation to go from. So I think the future looks bright. So thank you very much, Lori.
Thanks, Ross. Next, we have Dr. Emil Shemich.
Thanks, Lori. Hi, everyone. Mo, congratulations on an incredibly inspiring address. I was president in 2012. Back then, the issue of orthopedic person power and the unemployed orthopedic graduate was really the #1 priority. And at that time, there was really a major crisis in this area. As a result, the COPEF and National Standards Committee of the COA were both charged to make this problem their priority. There were a number of initiatives that were undertaken that were directed at understanding the supply and demand for orthopedic services and human resources. We improved the data around the problem to show what the impact was, both quantitatively and qualitatively. We started the process of developing a position statement on redefining what constitutes full-time orthopedic practice in Canada. We're heavily involved in a lot of decision-making around residency training positions. At one point, positions that were funded were up to 80 plus a year, and it was really the feeling that those levels were too high. And so there were reductions, and current levels are in part related to this decision-making. We're also heavily involved in advocacy for public funding for new orthopedic positions and the resources required to support them. We focused a lot around other related areas, so things like locums, serial locums, transition planning, new models of care to try and help address the problem. So I would say that although the orthopedic HR problem still exists, I think the situation has improved since 2012. Thank you.
Thanks, Emil. Next, we have Dr. Ed Harvey.
Hey, how you doing? Oh, I got my stupid background on there. I shouldn't have that on there. I'm going to take it off because I just wanted to share my sweater with the rest of you. Okay, this is for Peter McDonald. Peter McDonald should be doing my job right now. He should be the team physician for Canada's team in Vegas, but unfortunately I've been traveling with our team. So Peter, I apologize for taking your job. But I was the president in 2013 to 14. It was a great experience. I think my most memorable experience was meeting physicians from across Canada and interacting with Canada policy. It was great to be on the carousel. It was a nice experience, but really what I came away with meeting a lot of people from across Canada, and that was the most powerful thing I think as a COA president we could do, is interact with people in the provinces. Definitely made people in Quebec feel more belonging to the whole group, and I think future presidents after me are just an indication of that. The major challenge in my year was for the COA was still manpower. So, and it wrapped over into actually Baz Masri's year. So it was a 3-year project really that Emil was spearheading, obtaining data and getting a handle on what was going on. And it was recognized through the data acquisition, as Emil said, that it was really not a problem with manpower. It was really a problem with resources at the local level. Now we've kind of solved the manpower issue. It's an artificial solution though, because the real problem is resources. Our patients are still suffering. I think although advocacy has come a long way, we still have a way to go, and we need to speak out for our patients a little more. There's, especially now with COVID, it's going to be a huge red flag what's going on with surgical resources. I mean, I haven't had I shouldn't say that. I've had 2 elective rooms in 14 months. So my elective practice is basically done. So that's why I have my side gig with Montreal Canadiens. But the other things that went on with the COA that year were really machination problems, things that were important for the running of the COA. We kind of cemented the pillars and function, and using the legacy of all 5 presidents on the executive board to help. We transitioned to the new rules for nonprofits. So that took up a fair amount of our time that year, but that's been cemented. I think I missed a couple of years at the end because I tried to die in 2014, but I've recovered and am back. So I was happy to recover from that. But I think the COA's got a bright future going forward, as Mo has just reiterated, and I think we could all help with that. And thanks for letting me talk.
Awesome, thanks, Ed. And last but not least, Dr. Peter McDonald.
Thanks very much, Laurie. And congrats to Ed on the Montreal Canadiens success. I am cheering for you guys now. Congrats to Mo and Keish and Laurie for your leadership. Mo, that was an unbelievable speech as usual, but we're in great hands with Keish and Laurie following. And it's good that the COA has a great future ahead of us. It's great to be on a panel with so many distinguished Canadian orthopedic surgeons. And during my presidency in 2016, I was grateful for the leadership of Robin Richards before me and Kevin Orrell after me. And Doug Thompson's already been mentioned by Keith as being integral to success of the COA and the running of the office. He made the presidency so easy just by telling me what to do, where to go, and what to say. Our issues continue to be the job crisis, the decrease in resident positions across the country. They're up to as high as, I think, 85 admissions to orthopedic surgery programs across the country. One year, we're now in the mid 40s, and so that's probably more appropriate. Actually, I was guilty 10 years prior to that, being on a manpower committee for the COA and advocating for more residency positions. because we thought that the baby boomers and more government resources would flow our way. The baby boomers came, but the government resources did not. And it's unfortunate we had to adjust resident numbers. So I think that's starting to correct itself, and you can see that jobs are becoming a little more available for our graduates. Advocacy was done. We continue to emphasize wait lists, and for the leaders, Keish and Laurie, who follow, the post-COVID wait lists are unbelievable. So there's a huge challenge on catch up, which is going to obviously take years. We also recognize diversity. We had, I think, up to 15% of COA members were female during my year. I think there's only one Indigenous member. So we need to be more diverse, and Laurie's going to do a great job on taking that to the next level. The subspecialties, we started to recognize that subspecialties were starting to drift away from the COA, such as the Spine Society. We needed to work hard on trying to bring them back and make them integrate into the COA, make their lives easier to be part of us rather than away from us. And I think that the COA has continued to do a great job to embrace subspecialties and foster their development. We actually consolidated the fees for the annual fees for the membership and the annual meeting were consolidated. Whether or not that was a good move, I think it made things simpler, but time will tell whether it was a good move. And we continued to promote value adds such as orthopedic evidence, which Mo's done a great job with, and the registries were also mentioned previously. So it was a wonderful year. We made some great friends in our travels with the carousel, and hopefully we as an executive were able to make a difference and make the COA a little bit better than it was before. Thanks.
That's great, Peter. I wonder if I could ask all of the presidents now to come onto screen. And while you're coming onto screen, I'll just kind of reiterate just how amazing this view is. So for those of you watching, get your camera out and take a picture. You're looking at Canadian history. You're looking at over a century of orthopedic leadership. You're looking at centuries of orthopedic mentorship. And you're looking at a number of individuals who themselves share many friendships. Before we got on this call, there were so many chats ongoing. So I'm going to ask a couple of, I'm going to ask you all to think about a few things while I maybe target a few people to give their insights. But each and every one.
Let my video come on there, Mo?
No, it hasn't come on yet, Russ.
No, Mo, it's halted by the host.
Oh, okay. The host, yeah. Okay, there we go.
Oh, thank
Great.
you. Got it. Thank you.
So what I would say is the following. As you all look across this screen and you see friends, I would be very interested to hear stories, and I'm sure our members would be very interested to hear stories that you might have about somebody else on this panel, a story that maybe you haven't shared or a story that maybe many don't know. And I thought I'd ask you to reflect a little bit on that. And then as you come up with an idea, just basically unmute and we'll let you speak. This is meant to be very conversational. But while you're thinking of those stories, the one thing that definitely struck me today for each and every one of you, in many ways has opened doors for all of us. And for me personally, and we don't get a chance to thank those ahead of us who have really made huge impacts. But the one thing I also reflect on is that nothing ever happens in isolation. And so for many of us during our residency, we had heard so many powerful partnerships, duos, groups. Some of you have been named in those groups, and maybe either to your joy or to your dismay, you've heard of Tyler Schatzker or Schatzker Tile. You've heard of Cruz and Rennie. We've heard of Rohrbeck and Bourne. We've heard of many, many amazing partnerships and friendships. And I wonder if I could just ask Dr. Cruz, if you wouldn't mind, just to speak a little bit about the importance of, having important partners in your leadership journey.
Good leadership isn't telling people what to do. It's making people want to follow you. And I don't think you can do it by yourself. You mentioned Bill Rennie. I was actually the first head of orthopedics at McGill because we had no structure before. And the first partner I had was Nelson Mitchell, who many of you will not remember. Nelson did a McLaughlin Traveling Fellowship and came back. He was an outstanding orthopedic surgeon. He was a resident when I arrived in Montreal. He then he spent the 2-year McLaughlin at Oxford studying electron microscopy, and probably was the outstanding individual, forget orthopedic surgeon, in terms of the ultrastructure of cartilage with Reg Cooper in Iowa. And he and I, he was as responsible for any of the accomplishments at McGill as I was. We were partners. Bill Rennie arrived as a resident, trained with us. We arranged his fellowship in hand surgery at Columbia, and he then went to Winnipeg, and our hand surgeon, Jacques Dumont, left, and we brought Bill back. And Nelson by then was frankly doing his own thing, and Bill essentially ran the orthopedic service. So having wonderful, competent people who just absolutely have to be your best friends makes leaders look good, but it also makes them be effective. It's a kind of a long, rambly answer. My guess is that most people on this screen will have had similar relationships as they tried to do their leadership jobs.
Thank you, Dr. Cruz. Dr. Tal? Oh, you're just on mute.
Yeah, thank you for that, Dick. I also evolved in the world of medical politics, which is no different than any other politics. And you have to compromise. You have to have partners. You have to have mentors. Otherwise, you can really accomplish nothing. Just a couple of little stories. You mentioned Joe Schatzker. And of course, I had a Detweiler traveling fellowship from the Royal College in 1965, where I visited 3 people. Well, I visited many in Europe, but I got to see Morris Mueller in St. Gallen, Switzerland. I got to see Jip James and some of the other spinal surgeons, Alf Nachemson, for my spine practice. And in hip, I went to visit John Charnley. So just a few of the giants. And when I visited Morris Mueller, that was totally by accident, because I wanted to do trauma. I was in London, and Alan Letton, the president of the BOA to be, said, "You're not going to Switzerland? What, are you crazy?" And I changed my whole plan with George Pendle, went there. Joe Schatzker was 2 years behind me, and he was going to spend his entire time in Gothenburg. And when I got home, he was my resident. And I said, "Joe, you got to change. You got to spend a year in Switzerland with Morris Mueller." And that's how he got involved. But to shorten the story, Joe was asked to do the American Academy course in 1970, because no American would accept the AO, internal fixation of fractures. And he asked me to help him. And that course went on for 25 years. And just an interesting little, the 2 of us then published our textbook, and on and on and on, and the rest is history. But with the very first American AAOS in Dallas, I spoke on fractures of the tibia. There were more than 500 people in the audience at our instructional course. And when I said open fractures of the tibia should be stabilized, 500 people got up and booed and hissed and screamed obscenities because the Surgeon General, this is the Vietnam War, the Surgeon General said, you do not put metal in open fractures or anywhere around them. And a man named Reynolds became the head of the AAOS the next year, and he said the AO is right and we should be, and we never looked back from there. So that's just a funny little story about how we got going in the AO. And of course, I became the first non-Swiss president in '93, right after the COA, and Joe 3 years after that. So that's our other accomplishment. So yes, it's important, to listen. It's important to collaborate with other people. In my time as Surgeon-in-Chief at Sunnybrook, and Jim will know this, and anyone else who's been a Surgeon-in-Chief, you really got to have the backing of the psychiatrists and the medical people and everybody else, or you can get nowhere. I think it's a very important message that Dick Cruz mentioned, and I totally agree with you, Mo. Take care.
Thank you so much. If I could just ask Dr. Rohrbach, when you started your program of research, did you have a sense that it would have the impact it does? You know, sometimes you start something and you don't really appreciate it, and maybe now you look back and maybe you can appreciate it, just how much of an impact your work has had, not only on Canadian orthopedics, but I think globally. Oh, you're just on mute, Dr. Rohrbach.
You'd think I'd never done one of these things. You know, is there a pandemic out there? Which I spent all my days on all this. But in any event, thanks for your nice comments, Mo. And Laurie, it's great to see you. Laurie spent some time. I hope it was good time at the University in London. So it's lovely to see you. Yeah, I mean, these things I think happen largely by accident and serendipity. When I went to London, Charlie Drake, who was the head of neurosurgery, he said, Rohrbach, I said, yes, sir. He said, do you have an MRC grant? I said, what's that? And anyway, to make a long story short, we were able to get an MRC grant. And at that point, Bob Bourne arrived. And the two of us were doing a boatload of artificial joints. And so Bob, I think probably, because he was pretty tuned into this, said, we really need to get a registry going here, and we need to combine with other people. It's not just, this isn't just about orthopedics, it's about lifestyle, it's about going back to work, it's about relationships and so on with family. So we happen to have an organization called the Robarts Research Institute in London. And we had a guy by the name of Andreas Lapakis, who I think is at St. Mike's, Jim, or was last time I checked. And we had a very close relationship with the healthcare economists and so on at Mac. And we all worked together on this in terms of developing our facility largely at the Robarts, but under the leadership, I guess, of Bob and I, but it was other people that made it successful. And I guess for the young people, it doesn't matter how smart you are, and everybody is so smart, but a lot smarter than me anyway. But the thing that you must not overlook is that there's people around you that have expertise and skill sets that may not say too much about it, but if you look, they're there, and they can do so much to help a success with a common sort of purpose and attain a very worthwhile goal. So that would be my message, and we've done that all our career and still do it to some extent today, and it's been a very, very good thing.
Right. Thanks, Dr. Rohrbach. You mentioned Jim Waddell a few times, and I'm just going to, if I could, just take the moderator prerogative to get Dr. Waddell to say a few words. And maybe if I could, Dr. Waddell, I mean, certainly you can reflect on any story you wish, but you're also leading right now in some other large orthopedic organizations. And I've always been curious about how leadership for you has changed over the years. All of you in many ways have been, continue to be leaders in other forms after your presidency. How are things different now than they were? Oh, you're just on mute, sorry.
Thanks very much. I think leadership, I don't think has changed that much. I think it's a little more challenging now because there's a lot going on. You know, there's a lot of things happening. But I would agree with what's been said already. That the key to this is to ask people to help you. You know, the key to leadership is saying, look, I have a problem here. I think you can help me with this. And you have to demonstrate to the person that you're asking, first of all, that their input is valuable. And secondly, that there is some reward for them, tangible or intangible, in helping you. And so organizations like the COA, like the annual meeting, we all get to know each other so well when we get together for a couple of days. And you recognize in people the strengths that they have and what they can do for the organization. And I think that's crucial. As Cease said, you know, you have a bunch of people that, is that a gin and tonic you're having, Cease? I guess so, 220. There's so many people in the organization that can help you. And the essence of leadership is getting people to pull together. And the challenges that you've had in this year are almost unimaginable to me. Try to run this organization in the absence of the annual meeting and all the rest of it. You're lucky you've got Cynthia and Megan and people like that to help you. COA, which I'm involved with now, has members from 90 countries. And we really depend on our annual meeting to bring everybody together. We haven't had an annual meeting. And so these are real challenges. Try to motivate people remotely, keep track of their organization, keep track of their things. But the key always for me has been to ask people to do things. I never tell people to do things.
Thank you. If anyone has a story you want to share, please just let me know or unmute. If there's someone else you want to, if there's a beef you want to settle right now with someone, it's right here. Let's do it. Okay, I heard Dr. Layton. Dr. Layton had his hand up, and I know Ed's got beefs. Come on, Ed.
Yeah, no, I just have a small story. As you know, we started the COTS organization, and it's been very successful. But one story that people probably don't know is that Emil told me I was a young guy who had a plan, wanted to do a study, and could he come and present to our group. So he thought he was a pretty good guy. So I said, well, come on along. So we're going to meet in Vancouver. And this guy arrived and he started talking about tibias and what we should do with tibias. And that, of course, is Mo, was you, right? So he came to the meeting. And I met this young guy and I said, he looks like a pretty bright guy and he wants to do this study. So tried to talk everybody into doing this sprint study, never realizing that it's going to take about another 5 years to get it done, right? But anyway, it was kind of funny because I'd never met you before. And I dragged you all out to Vancouver to go to a meeting for about an hour, but it was very successful. And I think that that's how the COA and the OTA and the COTS meeting behaves, is that they bring new people in. And I think that as leaders, it's more to promote people to do the things that they do best and make your organization better. And I think you're a classic example of that. So it's just fun for everyone to know that you can start from 0 and go to 60 pretty quickly. So.
You know, and I remember that meeting. I mean, like it's yesterday, because it was one of those things where there was like, you know, I just as a resident contacted everyone, and I was shocked that everyone had accepted. And I said, oh my gosh, they're all coming. And there's this room, a long boardroom at Vancouver. And I remember at a point, like I was just, you know, nervous. I was kind of trying to get through a meta-analysis. My hand was shaking on the thing. And Gordon Guyatt, you know, at McMaster was a professor of epidemiology, and he saw this thing going down. Like, because you know, U.S. and Canadian surgeons were kind of arguing, saying you can't do reamed. And Paul Ternetta, someone might know, said, you know, if you don't know how to do it, I can teach you. Like that kind of stuff was happening. It was really pretty interesting. And I'm thinking this is going very wrong. And Gordon says, okay, you know what? We thought we could do something really exciting, and we bring people together. It sounds like I, you know, kind of wasted my time playing here. Thanks so much. And he just got up and mid-meeting was going to leave. And I'll never forget this. Everyone got up and said, no, Gordon, sit down. No, we're buddies. We're in. This is just how we communicate. We're good. We're good. We're good. And everyone went forward. And that moment was the beginning of something. Because if that had gone south, there was no sprint. There was nothing. There was nothing going to happen. So it's a pretty It's in my head forever. So
Yeah,
thank
they
you for
didn't know
raising.
that's how we communicate. We just
No,
argue.
not
and
a
have
clue.
fun.
Yeah.
We thought it was fun.
Yeah. I said, wow, that's just how everyone does it. Got it. Anyways, any other stories? Anyone want to share? Oh, I see our head. Yeah, sure.
So no beefs, but I just follow on the COTS study. The COTS group's been one of the best things about the COA for me. But I would never have been a trauma surgeon without someone else on the panel right here, Peter O'Brien. So I, as a medical student, wanted to do a hand fellowship in Vancouver with Peter Gropper, and they said, you can't do 4 weeks. You can only do 2 weeks. Well, you got to do something else. And I said, okay, well, I'll do trauma. And I spent 2 weeks with Peter O'Brien, and it changed my life. So I got to say thank you, Peter.
That's good.
Peter, you might have a comment for that.
Well, that's very kind of you, Ed. I guess I have two stories maybe that I can share. One is when I was the president, Emile was on the board, and I knew Emile as a really brilliant clinician and scientist, both in clinical research and in basic science research. But what I didn't understand about him, and I learned that year, was what a wise individual he was. When we had a difficult issue to deal with, he always came to the point, and the advice that he gave us, we could always count on. So, Emile, I want to thank you for what you did that year. And I also want to share a story about one of the board meetings. Mo, you were bringing forward a proposal about intimate partner violence.
Oh, right.
And I read that proposal before the board meeting and thought, this is a motherhood issue. This is something that the COA needs to support because it's so important. But when the board meeting got underway, as typical of COA members, question everything, challenge everything. The conversation was again going south. It took a little emotional outburst from Mo to bring everyone back to the fray and realize that this is something that the COA needed to support. So that was another little interesting little story we had.
One thing I will say is that once the leadership comes together in orthopedics, it just becomes the advocacy issue and everyone buys in. But you need information, you need data, and it was our job to do that. Emile, did you want to say something? I know you were named a couple of times here. Did you have any comments? I want to make sure those who want to speak get a chance. As time flies, we're in our last few minutes here. This could go on happily for me for another 2 hours, but I suspect we're going to have to end it soon.
I just wanted to say that I think the difference between the COA and other groups around the world is I think we're just sort of a large extended family. Like the reason I think COTS works so well is that essentially we all get along. And in the US, for example, there's often issues with proving that you're right. Whereas I think you go to a COTS meeting and people shoot you down. But there's never any hard feelings. Like I remember a couple of years ago, I went, with a proposal that I carefully planned, worked out, and thought it was going to sort of be the next latest and greatest. Went there and presented my proposal, and 40 people told me I was an idiot. So, I mean, people literally are able to sort of, communicate. There's no hard feelings. You go away, you make your research better. And I think, Canada as a result benefits, as does the rest of the world. And I don't think there's anywhere else, on the globe that we'd be able to do it that way. So I think it's real testament to what happens in Canada.
I'd like to add a little something to that. As many of you know, I've had a varied career since I was last in the operating room, and been heavily involved in education, and for the last 25 years, research into education. And I'm going to hopefully say something which will help to explain this. We've come to understand that education is not so much involved with the transfer of knowledge, but that it's a social process that involves not only knowledge, but social interactions with other people. And one of the most powerful social learning theories that's out there now is called communities of practice. And it's very powerful. It's not just in medical education, but in the wider pedagogical things. Community practice says that people voluntarily wish to join a group, and they move from being peripheral members of that group to central members. And in so doing, they accept the values and ideas that are important to the group, and they acquire the identity of the group. And once they join, the group becomes hugely important to them. When I first read them, and by the way, my wife is has done this with me, and hello to Esther. When that first came up, I all of a sudden understood what it had meant to be an orthopedic surgeon. When I stopped being an orthopedic surgeon and became a dean, I didn't miss being operating. I missed the company of surgeons. I used to go back to the coffee room at the Vic to have coffee and talk to the surgeons as they changed between cases. When I would go back to a COA meeting, it was like going home. I frankly never had that feeling when I went to the Association of Canadian Medical Colleges, of which I was president and stuff. It's that sense of community. And orthopedics is the strongest. I've had a fair amount of experience, obviously, as dean. I think orthopedic surgery is the strongest of the communities within the medical family. We all, we exchange children in the summers. Our son went with Willie Tayard in Geneva. His son came to us. Carol Laurent had a host of people coming in and out. You don't do that with strangers. You do that with people who you trust, who you like, with whom you share values. So, a lot of what we've been saying this afternoon, I think, builds around that. Anybody who's interested, there's a big literature on community and practice, including a couple of articles by Sophie and I. But anyway.
Well, thank you. And unfortunately, this hour has come to pass. And on behalf of both my co-moderators, Dr. Mulpuri, Dr. Heemstra, I'd like to just once again, for everyone listening, you need to hear these names, because this is, a once for me in a lifetime opportunity to say thank you to each and every one of you for representing Canadian Orthopaedic Association, and certainly opening doors for all of us. Peter McDonald, Ed Harvey, Emil Shamich, Ross Layton, Peter O'Brien, Brendan Lewis, Robert Hollinshead, Clive Duncan, Cecil Rohrbeck, Jim Waddell, Marv Tile, and last but not least, Dr. Richard Cruz. Thank you all, and wish you all a great afternoon.
Great seeing everybody. Take care.
Take care.
Great. Bye-bye.
Thank you.